myself to work in partnership with PDA on setting up. It was in Wayne, Pennsylvania in April of 2010, where we met a regional PDA meeting, and Chuck Pinocchio, myself, Tim Carpenter, and a couple of other activists met privately off to the side at one point and talked about whether or not it would be beneficial to form a group that could provide information from all the states working on universal health care, single payer, Medicare for all measures in their states, and maybe share some of the knowledge and some of what's worked, some of what didn't work, and be able to advance the movement that way. And had I not been supported in that work of traveling all the heck all over the place to help do this setting up of people being integrated in a network, this movement would not be moving forward the way it is. And I think one-payer states would not exist. So I want to thank Michael for that. Many of you know I worked with Michael. He was my boss. I was so blessed for 5 years to have him as my boss. The very first time, I'm kind of going in reverse, and then I'm going to jump it off to Michael, but the very first time I met Michael, among them, was when I was starting out on a Healthcare Now roadshow on a bus. And the bus was literally a 1980 school bus with 6 seats left in it. We were definitely on a budget, and we left Chicago, and we traveled through 12 states, 17 congressional districts, and then ended up in Pittsburgh, where I met Chuck Pinocchio for the first time. But Michael stepped on that bus, and he looked around, and he took a measure of how rough that trip might be for many of us. And I didn't work for him at the time and didn't work for the nurses at the time. It was before that. And he was kind enough to hand me his business card and say, if you need anything, you need to call. And that was one of the nicest, kindest gestures. I know we often see Michael in his role as a fighter, and certainly is one. And we see him in his role as an intellectual powerhouse on Medicare for all and single payer, which he is. And he's also, in my mind, one of the best political strategists on this issue that we have going. So I have been blessed to know him on many levels and care very deeply for him, and hope that you all will join me in welcoming Michael to this call so we can all learn some more. Michael, it's yours.
Oh, thank you, Donna. If I could live up to your kind words, I would be very, very grateful. I'm very humbled by your friendship and support, and your you've always put patients at the center of this movement, and it has been a real blessing to work with you, and thank you. And I really feel bad about that bus trip still.
It was pretty grim. It ended with a fire on the Cumberland Gap.
Exactly. But remember, we did figure out how to do those bus tours, and I'll never forget.
Yes, thank God.
Yeah. Who can forget confronting Cigna?
Oh, my goodness. Yeah. With Natalie Sarkeesian's family.
Yeah, with Natalie Sarkeesian and Hilda Sarkeesian confronting them, and Wendell Potter, and among others, looking down at us.
Yes, and the guy flipping us off from Cigna. Remember that?
I do remember that, and I will never forget it. The contempt that the insurance industry has for their so-called members, and the contempt they have for anyone who would try to create a humane healthcare system must never be forgotten. And so bless you for bringing those issues and really foregrounding caregiving and kindness. Of course, we learned that from the nurses, right? We have to do a shout out to the nurses, because so much of what I was able to do for those nearly 25 years was because of their leadership and commitment and focus on caregiving. So we have to keep that in the forefront. And
absolutely.
And thank you, Dr. Bill. I really appreciate your kind introduction too. Hope to live up to that as well. And you got to figure that if Chuck is taking a break in Beirut, we got to keep him in our thoughts as well, because that is a tough place to be. That's for sure right now. So I'm looking forward to talking about kind of the these issues of HMOs and just kind of drill down on some of the specifics. I have followed some of the listserv back and forth on one pair of states, and just I feel compelled just to say a couple things to set the record straight, because there are some mischaracterizations of me in that. So I just, not because I don't think it's germane to the policy debate, but I want to make sure that folks know that I am not dedicated my work since 2018 to creating an HMO loophole for single payer. I did organize a national campaign for Medicare for All that was significantly funded at a level much higher than anything we had done before through NNU in 2018, and it wasn't my choice to end that campaign. And had that campaign continued, it would have resulted, I think, in a much different political landscape. We would have done 300 town halls in November of 2018, and I think characterized the election results very differently. So it really isn't the case that I favor an HMO loophole. It's not even the case that the difference between the bill I worked on, SB 562, and the current bill in California, AB 1400, is a difference in authors. I was proud and really grateful to work with Carmen Comsty on 562. She wrote chunks of it, did a lot of the drafting of it. And I really admire her work on AB 1400 and on the Healthy California for All Commission. So I think one of the things that we don't want to do is create false dichotomies or hypothesize about people's motives or intent, because that's counterproductive. And it's let's remember that we're a movement to bring, as I said about Adana, kindness and caregiving to an inhumane, murderous healthcare industry that is killing us, denying us care, and taking profits that are ill-gotten and enriching the wealthy at the expense of people's health. And that's unacceptable. And we are a movement to save lives. We're a movement rooted in kindness and caregiving and compassion. And there is no place in our movement for the kind of hostility that has sometimes been present recently. So I would just second Mike Huntington's direction on this, and really appreciate, Mike, all your work on it. I mean, let's face it, this context that we exist in, yesterday, the Supreme Court upheld, or at least dismissed the case and seemed to definitively upheld the Affordable Care Act. That's great for us. Now we can get beyond having to defend or, be where we certainly don't defend it, but for those who felt compelled to do so, not relevant really. Let's figure out what we're going to do, because the bottom line is the ACA cannot guarantee healthcare to everybody in the US. It simply can't. Its priorities are what we call a kind of neoliberal approach, or an approach that says the private market is preferable, that we might be able to regulate some of their behavior, but profit making is a fine incentive for healthcare. And in fact, we're going to use tax dollars in a public-private partnership to subsidize that profit making as a vehicle for coverage. And it represents a fundamental compromise in values and policy against the interest of patients and all of us in the healthcare system. And so we need to really struggle against all the imperatives that the ACA has laid down. And secondly, let's not forget who the real enemy is. It's not people who we need to win over. It's entities like United Health, who made $4 billion, and I think it was the second quarter of 2020 and during the pandemic. And more prominently, it's private equity. Private equity is increasingly playing a huge role. Look what they did to Hahnemann Hospital in Philadelphia. Look at the role that they're playing in the nursing home industry. Look at the role they're playing in closing hospitals and stripping of assets in favor of real estate interests and others. So these are the real fundamental corporate entities. And look at the health plans behind Medicare Advantage. This is what we confront. Huge, powerful special interests with literally ultimately probably close to $1 trillion in assets and revenue that are against us. So let's not forget the enormity of our political challenge and the financial power that is brought to bear against us. And so I want to, just in terms of what we're talking about when we talk about some of the reforms we proposed in California in relation to this, and I want to thank Stephen Kemble for a really enlightening recent discussion and his ongoing work, because I think it really brings to the fore the key role that insurance risk plays in potentially undermining a single payer system. But I want to start with what we are talking about when we talk about payer, in my view, what kind of the fundamental mandates are that characterize our approach. And it starts with guaranteed healthcare with no barriers to care. And that's primarily, that's a fundamental difference from the ACA right there. That simple phrase. The ACA doesn't guarantee anyone healthcare. It provides coverage, not even on a universal basis, but as we know, coverage is not care. It doesn't eliminate barriers to care. In fact, the premise of the ACA, the premise of the Obama White House when they designed the ACA was that patients had to have skin in the game so that they paid for healthcare and disincentivized overuse. Their claim was people use too much healthcare. And in a country that where that's simply not true, that has the shortest length of stays of any comparable country in hospitals, that goes to the doctor way below average of similar countries, basically a third as much as folks in Japan, where at least 25% of people in this country don't get care because they can't afford it, because of the basic and huge inequities based on race that have been exposed by the COVID pandemic, by the marginalization of LGBTQ people. We should recognize Pride Month. My own experience surviving the pandemic, the AIDS pandemic, in the 80s and 90s, when there were really no treatments for HIV/AIDS until the mid 90s. We saw what happens to marginalized people that are shunted aside by the healthcare system, and in many unfortunate cases by their own families, and by the Reagan administration, whereas at least 300,000 people died as a result. And that pandemic continues primarily in countries of the global South, and also in communities of color in this country. And so we can never forget that this system, if they can't make a profit on it, they marginalize people and create barriers to care. So our first principle is guaranteed healthcare with no barriers to care. We also have as the principle a single standard of quality care. And that is a expression of the mandate for real equity, because of course our fragmented multi-tier system, again created or reinforced by the Affordable Care Act, basically says you rations care based on ability to pay, and says you can only get the care you can afford. So, hey, if you can only afford a bronze plan, you're going to get a different standard of care. If you've got a Cadillac plan through your employer, an executive plan, you're going to get concierge doctors, and you're literally, as an ER doc at UCLA told me, you're going to get different treatments, different prescription drugs, different protocols will apply to you. Different treatment options will be given. We know what happens to Black women giving birth. Their pain is ignored, their experience denied, and the mortality rate is 6 times what white mothers experience. So these have to be eradicated, and the mandate is for a single standard of quality care, creating real equity. And we next is a mandate that services are based upon patient need and medical necessity as defined by the provider. And the corollary is, as exists in say SB 562, the last single payer bill, and also AB 1400 in California, that the professional clinical judgment of licensed providers cannot be overridden by technology, by protocols. And it doesn't matter in which health system providers operate. It is a mandate that professional clinical judgment applies and cannot be overridden, and that those services are therefore provided based on patient need. We take a clear position against simply a protocol-driven system, and that is a direct challenge to how much of care obviously is organized and delivered. It's a mandate for comprehensive benefits and no carve-outs and no double billing or any kind of payment outside the system for those benefits that are covered by the system. And we need to understand, for example, the expansion of Medicare as proposed and is quite live, as we saw recently, I think yesterday, where the Democrats in the Senate are really devising a comprehensive program that would expand benefits in Medicare to include dental, vision, and hearing, and eliminate out-of-pocket expenses and lower drug prices. So it is vital that we understand that it's not up to any health system what benefits are provided. It's not up to any health system as to whether patients get those benefits and services. It's up to the providers, and it's a mandate by the system. And that we eliminate any incentives to deny care. There is simply no place in a single payer system for the ability of any entity to deny care. And again, based upon the primacy of clinical judgment, the single standard of care, the mandate for comprehensive benefits. And we also recognize that global budgets are a fundamental aspect of how we want to pay for services. And I think we can have a discussion about whether a system can exist on an integrated basis and still have global budgets by facility. I think that's a possibility we could get into. But global budgets as a fundamental aspect of ensuring that facilities, and particularly acute care facilities, have the resources they need, regardless of whether they're considered profitable by the current industry model. And this means we're not just talking about saving hospitals in urban areas. We're talking about reopening hospitals in urban areas. We're talking about reopening hospitals in rural areas. And when we talk about guaranteed healthcare and addressing community needs, we're really dealing something as well with the politics that exist around the feeling that, oh, someone's getting a better deal than me. There's creating a resentment that may exist. And instead, what we do with single payer is create a sense of solidarity rooted in justice. And so these are not just policy markers. These are policies that reflect our values. And we've seen in other countries like Canada and the UK that national healthcare programs emerge probably from a greater sense of solidarity, but really more important, create a sense of solidarity and create a sense of this is ours. This is our national health system. This is our collective expression of who we are as Canadians, and reflected in the Tommy Douglas being the most admired Canadian in history, who founded their Medicare system. Going along with these policies is that there's no private control of capital budgets. No healthcare system will have an incentive to create net income or profit so they can funnel it into a capital budget that funds their own expansion. No, that's not what's going to happen. Single payer systems control the allocation of capital spending. The system determines where facilities need to go and the kind of technology and services that are provided in specific communities based on the needs of those communities. So we eliminate any incentive to create net income that can go to capital spending. We have a clear recognition that we do not endorse and never allow value-based purchasing or what are called accountable care organizations. We, as Dr. Kemble has made clear, we cannot allow insurance risk. So these mandates leave still some questions we have to address. Given those mandates, can integrated delivery systems exist including, say, community clinic consortiums within a single payer system? And if so, how can they exist? And naturally, PNHP, of course, has done seminal work on this question many years ago. And it was reflected in HR 676 at the time, sort of referred, I think somewhat sardonically, as the quote HMO loophole. And HR 676 had very specific provisions about how HMOs might exist. They're nonprofit. They actually deliver care in their own facilities. They deliver it through salaried physicians who are employees of the HMO, cannot be contractors. Interestingly, another provision is they do not control hospitals. And if they do, they cannot use their capitation or budget payments to cover hospital services. They're very much in line with the mandate to have global budgets by facility. And they do not use financial incentives based on utilization. And it's very important that those, again, utilization is not controlled by the system, not controlled by financial incentives as it currently is, but is controlled by the professional clinical judgment of providers as mandate in the legislation. And that mandate exists in, as I said, SB 562, AB 1400, and it exists as well in HR 1976. Of course, it's very important that reimbursement rates are negotiated by the system and not individual employers. But I think those 5 principles of that PNHP laid out: nonprofit, actually deliver care in their own facilities, salaried physicians, do not control hospitals or don't use capitation or budget payments to cover hospital services, and no financial incentives based on utilization, provide a very good guidepost for how we can proceed if we do, in fact, want to include HMOs. And I think the corollary issue, too, that we need to address, as I said, it's not just, say, in California, a large system like Kaiser, though that's clearly the elephant in the room, but it's also consortiums of community clinics that value their ability to integrate services. And I think it's also the case that we have to recognize the pervasiveness of managed care as a organizing method to deliver services. 85% of Medicaid beneficiaries who get for medical services are in for-profit managed care. And that has to be unwound or taken over by single payer. And I often think that one of the things we need to start with, as Connecticut has, as Dr. Kemble has pointed out, is getting those for-profit HMOs out of Medicaid. And then we have to deal with care coordination, because the debate, for example, in California around the Healthy California for All Commission is, hey, we use managed care to coordinate care. And one of the provisions that both SB 562 and AB 1400 has is on how you can carry out care coordination in a single payer system. And arguably, it's a complex system. You need help navigating it. Arguably, there should be a role for things like union trust funds that can help their members access services, or even provide clinics for their members to get services from. And it is something that I think we wrestle with and recognize that a system as complex as ours may need something beyond an individual just kind of calling up a physician or going to a hospital to access services. And so so care coordination needs to be elaborated on and I think considered in how we organize access to services. Ultimately, I think the question we face, as much as we create this policy, set of policies that are rooted in this, fundamental belief in guaranteed healthcare with no barriers to care, is can we get this done, for example, politically in California, if it means there's a breakup, so-called, of Kaiser Permanente. And that really speaks to the key political question, because you've got a system that covers 7-8 million Californians out of a population of 40, huge percentage of those members are in unions. And as we saw in New York with the failure of the New York Health Act to get a vote in the legislature, unions emerged as a barrier to getting that vote. And I thought the organizer for the campaign for a New York health plan had it right. I mean, she said, look, we don't consider unions our opposition. The industry is the opposition. We consider unions to be organizations that we need to win over. And that's how I think we need to approach these questions as well. We're not going to convince Kaiser that the elimination of the Kaiser health plan and going to global budgets in their facilities is something that they're going to like. But what we can do and what we must do is we must engage with those members of Kaiser to say, we have a credible plan that will preserve what you like about Kaiser and eliminate those denials of care and those egregious practices, and establish, for example, mental health parity, which Kaiser does not provide and which is subject to significant lawsuits. And there's just a fundamental failure there in providing real parity for mental health care services. And that's really one of the fundamental things that we bring in a single payer system is mental health parity. So when we confront the issue of integrating Kaiser or not, or allowing Kaiser, I think we could apply the 676 principles. I think we could figure out a way to do global budgets on a facility basis. And if we are able to enforce the mandates, then it is perhaps possible that we can eliminate any downside to per capita payments. I don't think that's out of the question. I think it's a compromise. I think that we have to wrestle with how we organize and address key constituencies who rely upon Kaiser. And I don't think we can shunt aside the question that a retiree posed recently on a Zoom I was on is, hey, I got great benefits. I got a pension plan that pays for my retiree health care, don't really have much out-of-pocket expenses. What is it going to cost me under the new system? And so we can't ignore the financing, I don't think, when we talk to union audiences. That's the experience I've had working with the Debs Jones Douglas Institute and really working with union members. They want very specific questions, and they want very specific questions when it comes to the current services they rely on Kaiser. And we have to recognize finally that whenever we talk about per capita payments, it's always, and I have kind of gotten this debate. It's so funny during 562, Dr. Bill mentioned those hearings. What we got pilloried on by the legislators was not the so-called HMO, exemption, but it was, well, why do you guys believe so much in fee-for-service? Fee-for-service has all these excesses. Fee-for-service is the problem. And you guys are just going to let everything be for service. And we know all the incentives for overtreatment and cost overruns that creates. And so it's quite ironic in this situation because, that is where a lot of these policymakers in California, they're so wedded to managed care that our task is to decouple all the incentives that have been created by managed care to deny care and utilize utilization to create financial incentives to deny care. That really is a primary political task. But we do confront some of the excesses of fee-for-service. We do confront some of the cost differences. My own experience in a fee-for-service situation when I went to a hospital was triple what a similar hospital stay cost at Kaiser. And so those differences obviously impact the cost of a single payer system. So those are some of the things I think we have to take into account on the other side when we address the potential for per capita payments or not. And then finally, other national health systems, which have obviously solved the cost problems generated by fragmentation and administrative waste and profit making, because they've had long-standing national healthcare systems, also find a role for per capita payments. And we may need to consider that experience as well. So those are kind of my opening thoughts, and I welcome the discussion. I don't think these are settled questions. I don't think they're purely policy questions. I think they're questions of political strategy, of organizing, and the ability to, particularly in a state like California, prevail against conventional wisdom about managed care and change policymakers' view of what it means to guarantee healthcare with no barriers to care. So I just want to thank One Pair of States for having me and look forward to the discussion. Thanks a lot.
Dr. Bill, thank you, Michael. Dr. Bill, with your skills of leading discussions, can you sort of take over?
Well, thank you. Thanks so much, Mike. Thank you, Michael. That was a terrific lead in. And if we can, Mike Huntington, we could take raised hands, electronic raised hands for a stack. I know that's always the easiest way to put people in a queue. I would like to, if it's okay with Michael, I would like if Dr. Stephen Kemble, Steve, if you have comments to add on, because I know you've studied this in great detail and worked with your own state in Hawaii on this issue as well. If you have additions or other things to add to Michael's comments on this issue, I would love to defer to you first on the subject, and then otherwise we can engage in discussion here at this point. So thank you. Thank you all. Steve.
Okay, sure. The first thing is that I think everyone agrees that Kaiser hospitals and doctors are something we want to preserve, and we do not want any disruption in people's access to hospitals and doctors that they're happy with. And we also appreciate their tight integration of their electronic medical record and easy access to information across hospital and outpatient services that Kaiser has achieved. The question is whether Kaiser is actually a three-legged stool with one leg being the doctors, one leg being the doctors, one leg being the hospital, and the third being their insurance plan, the Kaiser insurance plan. And I think we clearly want to preserve the first two legs, but my position is that the third leg is actually a dead weight tail and not helpful to Kaiser. And it's actually detrimental to healthcare, because when you have the insurance function depends on having a closed panel membership and being paid per member. And if you're paid per member and you have a closed panel, then you have all the incentives of the insurance business model, which is to cherry pick healthy people, avoid sick people, skimp on care, pressure the doctors to spend less time with their patients, et cetera, none of which is helpful or in compliance with what we all agree a single payer system should accomplish. So to me, in order to have the benefits of Kaiser, you need to preserve the doctors in the hospital. You need to get rid of the insurance function. And that means it has to become open panel where there are no members and be paid what it costs to run their operations and hire their doctors based on a cost analysis, rather than saying, here's a fixed amount of money. If you can deliver care for less than this amount, you can keep the difference and make a profit off it. We can't have that. It's incompatible with all the things that Michael just laid out. So we need to persuade unions and Kaiser members that we're not going to threaten their doctors and hospitals, but we are going to remove the insurance functions of Kaiser, not have it be paid per capita, not have members, and open it up so anyone can receive care who wants there. They won't get a surprise bill if they go out of network. All those things would go away. So that's my position on this. I don't see how you can be paid per member and not shift insurance risk.
Stephen, I mean, I really appreciate your perspective on that. And I think, as you know, I basically agree with it. My question is, what we do with global budgets is we make sure that, as we discussed, there's no place for that money to go, right? And so the question is, if we set up these mandates that I described, can we do the same thing under per capita payments? It looks like the money, there might be some money that goes to, say, we preserve some administrative structure for Kaiser so that members can, that they can still have specialty services in one hospital versus another, say. But that's the question. Can we eliminate, since we control the capital budget, since the health plan function goes away, can we eliminate places for the money to go so there's no incentives to create net income?
Okay, if you try to do that and you set it up so that the Kaiser entity is not allowed to retain profit, they're only given a global operating budget and money for the salaries for the doctors, no money for corporate change. And then you say, but they're going to be paid per member and have it be a closed panel. What happens if they spend more than that budget, or if they spend less than that much budget? Is there an opportunity to lose money or make money off the capitated budget? If so, insurance risk has been transferred and you have all the problems of the competitive insurance business model. I don't see how you can pay per capita and then say, but if you have any money left over, we're going to take it back. Why bother to pay per capita? And why not just pay them a global operating budget, not per capita, and let it be open? And if it's open, it's not a problem getting referred to some other center that has more specialized care for a particular problem because it's open.
Yeah, no, I think that's exactly what would happen. You'd basically say, okay, we're going to set rates. Oh, you made money on these rates. You're going to have to reimburse the system for the excess. And you raise a good point. Why do it? And I think probably the only reason to do it is because politically it's easier to win if we do it. But I think that remains a question, right? Whether we can persuade, unions who are invested in that system that our approach will in fact preserve their members, what they like about it in terms of going to Kaiser hospitals and doctors. I think that would be the only reason to do it, is basically if it becomes a political necessity. I think on policy grounds, you're right. Why bother going, having to jump through that hoop? Ultimately, we don't want that money to be able to go anywhere. And we want to, I think it seems possible that we could allow some kind of existence of the system and still provide global budgets on a facility basis and for doctor salaries. But I think it's a legitimate criticism to say, why bother? And the only answer might be political. Yeah.
One other thing I want to say about global budgets, because absolutely hospitals should be paid with global budgets, which eliminates fee for service for hospitals completely. There is no fee for service if the hospital's paid a global operating budget. And the doctors who are affiliated with a hospital through a Kaiser-like agreement with a medical group in a hospital would be paid with salaries, which eliminates fee for service. The only place left where there is any fee for service is in independent doctors. And they don't have an employer, so it's hard to pay them with salaries. You kind of have to work with fee for service for them. But we are talking about eliminating fee for service for hospitals, which is where most of the abuses of fee for service occur, not with independent primary care doctors. It's with hospitals. So we do eliminate fee for service for the hospitals.
Let's
yeah, that's what, sorry, Bill, Dr. Bill, that's what I said too to the Senate committee. Exactly that.
These are the policy in the weeds on policy. But let's pull in some other folks too into the discussion, because I think there's some other aspects too we want to look at. But thank you both for that. So I see our good friend Maureen Cruz from Healthcare for All Los Angeles chapter has her raised hand, and then there was a great question in the chat posed by Harry Baker too. So Maureen, your question or comment for the group. Thanks.
Yes. Hello, everybody. Good morning, afternoon for some of you, and thanks so much for being here. Thank you, Michael, for all of your work, and Steve Kemble and everybody who's been working on this issue. My question is coming not about the budget system, but it's about coming as a patient from the patient sphere. I've been a member of Kaiser since 1960, and probably every member of my family has been through unions and such. And the last 20 years, I would say 25 years, the quality of care and access, et cetera, has been diminished. But that aside, it seems to me that capitation itself is a barrier to care. One of the things that the single payer bills do, like Jayapal and AB 1400, is to allow complete freedom of choice by the patient to have a system that is patient-centered, meaning if, that I can go where I want. Right now, as a Kaiser member, I cannot. And even if I weren't a Kaiser member, I would not be able to, because the networks are in play, and the networks are a barrier to care. So it seems to me that capitation, in fact, is a barrier to freedom of choice and a barrier to us choosing the care that we would prefer to have. It would be nice to go to Kaiser for the things I find excellent at Kaiser, and to go outside of Kaiser, go somewhere else for the things that I don't think Kaiser does well. So I think, we're talking about budgets and systems, and that's important. But in the end of the day, healthcare is about care for patients. And that's my concern, is that we remove these barriers to care, of which capitation, I believe, is one.
Well, Maureen, I really agree with you. I haven't had the same experience. I've got a somewhat complex health condition that Kaiser can't treat. And so I get Kaiser through my spouse, through Retiree Health, thanks to the union, in this case, NUHW. And I've gone to Kaiser Hospital for treatment. But on the ongoing access to these, because I go, like many people, we go to an academic medical center. They have a specialty clinic in my disease. And so I got to go there. And if Kaiser won't pick up the cost of those specialists, I'm going to be on the hook for, buying a plan that I can, go to their clinic for. So I totally get it. And I tend to agree with you that the closed system is in itself a barrier for that very reason. And the problem, of course, is we have to, Kaiser insists, hey, we can't operate unless we have members, unless we have, some way to, know who our members are and organize care on that basis. And I think that's our job, is to say, there's another way to do it. You can preserve the doctor patient relationships you have. You can preserve being able to go to the Kaiser hospital you like, but we're not going to create those kind of barriers that mandate people get care in a system that may not be able to provide it. So I think that is our task. I think it's an organizing task. I think the policy imperative is clear. I think the what happens to the actual patient experience, like yours and mine, is clear. And I think we just got to figure out a way to bring on the political support that we need if we and come up with a way to adequately convince people that Kaiser's wrong, that they don't need that in order to, I dare say, thrive. And one of the ideas that Steve and I talked about, yeah, there you go, is getting Kaiser doctors to talk to union members and say, hey, this system could work for us. This system could work for you, and try and find ways to reassure folks that, hey, this is not going to dismantle what you like.
Excellent. Well, thank you, Maureen. Thank you, Michael. This question from Harry Baker, I think it's from the Bay Area, Northern California, I think drills down a little bit on this issue that we're having, in California over different unions, especially either supporting or not supporting the current legislation, and over the Kaiser issue. So it says here, can you speak to what the Kaiser's unions want, and do they see Kaiser written into a future single payer bill where Kaiser would give up its insurance side and then share management of its hospitals with the California Single Payer Authority? Could Kaiser be one as an ally? I don't think it's a huge stretch. What's your vision? How do we like, say, amend or modify AB 1400 so it meets the expectations of the unions, especially involved in that Kaiser care model?
Well, I think we have to actually engage with these unions and ask them what they mean when they say their members like Kaiser. What do they like about Kaiser? What is it about Kaiser that works for them? And figure out, okay, well, then what do you want to preserve about Kaiser, and what are you afraid of losing? Because really what we're dealing with here, as we know, is what sociologists call loss aversion, that people are much more focused on what they're going to lose than they are what they're going to gain. And they're much more skeptical of what they're going to gain and certain when it comes to what they're going to lose. And that is what we confront here. So, and in a desperate context that healthcare industry has created, where people are just desperate to keep what they have because not having it means, you know, life or death. And this sense of loss or potential loss gets heightened when it comes to healthcare, because literally people's lives are on the line, their health, their access to services they depend on are on the line. So I think our vision is real fundamental engagement. So with these unions and with union members and with the folks who bargain contracts, and also the unions at Kaiser, you know, folks have talked about an alternative vision for those unions, where they become much more kind of, you know, on a worker owner model, right? Where they become much more in charge. Many Kaiser doctors feel they have great input in the system. Other doctors aren't so sure, right? As you well know. And it was originally designed to be a very physician-driven system. I think most Kaiser doctors would say it's a health plan-driven system now, and that's the problem, right? Yeah. So let's get back to a clinician-driven system where providers and clinicians are in charge. Now, the labor management partnership at Kaiser kind of faints in that direction in a sense. You say, hey, workers are empowered. But let's remember the premise of the labor management partnership at Kaiser is the business imperatives of Kaiser ultimately apply. That the bottom line is the business necessity for Kaiser. That has to be eliminated. And it's not a matter of it's not a labor management partnership, it's worker provider control. And let's talk about an alternative vision. Finally, there are large numbers of administrative workers in the Kaiser system. And including in NUHW, which is, you know, active in single payer, and unions that are not active in single payer, like United Healthcare Workers West, represent a lot of Kaiser clerical staff, administrative staff, whose job would be eliminated when you eliminate the health plan function. Even if, you know, some version of per capita payment remains, there are huge numbers of administrative jobs that are lost. And so I don't want to talk about just transition. I want to talk about worker security. I want to talk about security for workers and and that means income security, retirement security, job training security, all those things that we don't do and that workers are rightly skeptical of. So some combination of greater, a clinician-driven system with greater worker control, with real security for workers who may be displaced. Those are the principles we have to bring, I think, to the Kaiser unions and Kaiser workforce. And alternatively to Kaiser members who are members of unions, they're going to want to be assured that their brothers and sisters are protected. And also those Kaiser clinicians and workers can help convince the members of other unions that this change works for them.
And let me just compliment you on your insight, even though you were not involved, like say I was in 30 years of working inside that system, because frankly, I was so proud of the teams that we had on the provider side of Kaiser who did that work in quality assurance, in continuous quality management. We didn't think managed care was a bad word. We didn't think drug formularies was a bad word, because we sat down as teams and evaluated what needed to be done. We actually coordinated care so that people, and facilitated care so that people got what they need. And, and in the true sense of the term, health maintenance organization actually maintain people's health. So that side of Kaiser, I think, is potentially what we want to work with and keep in a single payer system. And that's the side that we want people, if they like that kind of a provider model, to sign up for and still be a member of. What you're absolutely right. What we don't want is the business model that shortchanges, staffing and facilities, and sees somehow as budget cuts are how the system thrives, if I can use that term. So thanks for that. Maybe we can go back to the stack again. I see Kay is next up with hand raised. If you have already asked your questions, you can lower your hand. If you'd like to ask another question, of course, you can raise your hand. We'll try to go to folks who have not yet asked a question. Kay Lasker.
Okay.
Hi there.
Hi there. I'm from Philadelphia.
Yeah, great to have you with us.
You've stated that we should look at as demonizing insurance companies. As a, I'm a local activist for the past 20 years. The question that comes to me is to what extent, what kind of language and to what extent. Today we say for profit, and that's our way of demonizing. In talking to the average person, I get the feeling that that doesn't relate. They don't relate to that. That's, yeah, it's a profit. Yeah, so what? They don't deeply relate. So I keep looking for other language. But how far do we go? For instance, versus the profit statement versus something like insurance companies are serial killers. All right. Is that going, at what point do we go too far where it's going to really be negative? And to what extent should we do? So how can we get any guidance or use, determine that?
Okay, this is, I really love this question in the sense that I actually think we need to bring a little bit more emotional heat to our critique. And I actually think that Mothers Against Drunk Driving brought the kind of heat on that issue that we need to bring on this one. And I don't hesitate to say that ours is a movement to save lives, which are being lost to a murderous healthcare industry led by the commercial insurers. And I agree with you. People hear private insurance and they kind of like private insurance. We've seen that in some of the polling. People say, hey, making a profit is the American way. So we have to elaborate a little bit and say, okay, a profit on a car is one thing. A profit on human suffering, that's out of bounds. A system that denies us care and kills us is out of bounds. So I do favor sharper rhetoric. And that may not be universally held because, it's seen as, well, we got to win over folks, more centrist folks. But ultimately, any family who's had real experience trying to get care in this system knows what we mean when we talk about denying care for profit or denying care that their doctor or provider has ordered. And they know what that means. We've seen this treatment for glioblastoma, a drug that is essential to that, used to cost, maybe $50, was bought up by another company. Now they charge $1,000 per capsule, and they're taking that drug out of Medicare Part D so that it's no longer available for discounts. And that drug is essentially the drug that keeps people alive, and taking it out of the Medicare formulary means people will die. And we saw that with the EpiPen. We've seen that with insulin. These are real stories of life and death. And I don't think we should be afraid to say that this is a murderous healthcare industry led by commercial insurers who are profiting off of human suffering, and it's got to stop. And we shouldn't be subsidizing with our tax dollars, and politicians who front for it are doing the same work that they used to do for the tobacco industry. And there's no difference between commercial insurance companies and tobacco when it comes to their toxic impact on people and on politics and society.
Recently, I tried using a profit versus fair profit versus excess profit. And that did register with some of my audience. I still think we need something stronger. I don't know how strong we can get.
Right. I think excess profit, I think people do respond to that. In our view, though, of course, anything over no profit is excess. But yes, I think people do respond to that. And the escalation of prescription drug prices is a prime example. And that's why negotiating prescription drug prices, limiting the cost of prescriptions enjoys such support. That's a very kind of atypical, you would say, mainstream view, that we can actually limit the profits or the prices of an industry, and yet it has great support. So I think that points the way to, and also I think people don't really want our tax dollars going to United Health when it makes $4 billion a quarter. I think people see that as excessive. And so we have to build on that. And I think we should try out as strong of rhetoric as we can and see how it goes. And if we have to dial it back, well, then let's figure out some alternative approaches. But characterizing them as they are, as a murderous healthcare industry that has, toxified our politics and generated huge subsidies for their excessive profits, I think could be effective.
Steve's got his hand up.
Can I?
Yeah, I want to respond to Kay's question with a little bit different perspective, which I think is very helpful. That what we need to demonize is not insurance companies per se, it's the competitive insurance business model, which is founded on capitation that profits from denying care and or preserves money for capital expansion by denying care. We need to get rid of the competitive insurance business model. When Connecticut eliminated managed care companies from their Medicaid program, they hired one of their former managed care companies, which was a local not-for-profit health insurance company, to be an administrative services only contractor to handle administrative functions like claims processing, credentialing, administrative support for care coordination services in the community, specialized programs for the mentally ill. They paid for those by paying a former insurance company just to do those administrative functions, but not to assume insurance risk, not to be paid per capita, to be paid what it costs to deliver those functions. And they went from being one of those hated managed care companies to being universally appreciated as a good guy that was helping facilitate healthcare. And it was getting rid of the insurance business model, even though they kept the company, that was the key to that transformation.
I would agree, Steve, and I really like that idea of how you can actually coordinate care in a non-insurance risk, a non-competitive model. And I think we also, let's not let the hospital chains, the corporate chains off the hook either, right? And because they've created, it's really a model where these entities, the hospitals and the insurers and the pharmaceutical companies appear to be competing with each other, but in fact, ultimately collude. As prices go up, they all benefit. And so they don't really have a problem with an environment where costs and prices go up, because their profits go up along with it. And so if the corporate chains consolidate and improve their bargaining position with insurers, the insurers will pay more, and then they'll get a higher percentage as profits. So it's really taking on the whole competitive industry model, right, and replacing it with the single payer model of guaranteed healthcare.
Cindy, you had your hand raised?
Yeah, I did. I just want to say, I work with union members all over California, and this question came up in our town hall the other night around what happens to Kaiser under single payer. And I know it's more complicated, but it's like in my 40 years of dealing with union members, and I'm still dealing with union members, is there are two kinds of union members. There are those that love the Kaiser model, and there are those that hate the Kaiser model. And it is so black and white. It is not gray. It's very clear. And when you say to those members that love the Kaiser model under a single payer system, right? And I'm going to say, I know this is kind of a hot term, but when I think of an integrated system, right, I think of Kaiser where you have the lab and the x-ray and the hospital and the physician's office and all of those services under one building. And workers like that because they aren't having to drive, right, or make appointments in different places. That's my interpretation of the word integrated delivery system. And I know it has other interpretations, but when I say to a union member, Kaiser can still exist, they just can't be an insurance company. They cannot accept or reject risk, right? And union members understand that, right? They can't be an insurance company. And if you have a guaranteed set of benefits, the state guarantees you those benefits, they can't be denied. It tends to, my experience is, it it levels out that, don't take that away from me, that fear that Michael so eloquently described about, don't take it away from me, because you're taking Kaiser away from me if you have single payer. And so I'm just saying that that's what's worked for us here. We saw it completely neutralize members on our town hall the other night. You know, we have 8 million insured Californians in the Kaiser system. And so I just, you know, I'm so grateful for this discussion and us to have it respectfully. I just want to say, from my perspective, I know Dr. Bill was a Kaiser doctor and can offer us lots of insight. I appreciate that, but no insurance, no competition, right? We can't have them competing with each other, because then it's a, you know, we're headed down a downward spiral. And I think people, in my opinion, like the system that I just described. So thank you so much for having this forum. I really appreciate it.
Great talking points. Thank you, Cindy. I would just quickly add to what Kay was asking about demonizing insurance companies, and actually taking the politicians who take money from big insurance and big pharma. The great work, those including Michael, who were on the Lancet Commission and actually came out with numbers, you know, follow the science, follow the numbers. You know, 40%, I think it was, that I always quote, 2 politicians' lives saved if we had a Medicare for all system. You know, COVID deaths prevented, 40% in their district. You know, that's not that's not hyperbole. And those are lives, mothers, fathers, sisters, brothers, aunts, uncles, who would be alive today in those districts. And I think we can hold them accountable for that. So I don't think there's anything wrong with it. Let's see. I know we're past the top of the hour now. Is that okay, Mike Huntington?
Yeah. Yeah, I see Bill's been waiting.
Yes, and thanks everyone for sticking with us. Bill Bronsted from Sacramento area and PNHP. Thank you.
Thanks, Bill, very much. A couple of things. I'd like, first of all, to direct people to look at the chat. There's been some wonderful comments in the chat. Maybe after this is over, you can make that available to people. Secondly, I think that we need to remember that this meeting is a meeting of an organization called One Payer States. And its purpose is to generate major campaigns, state by state, in order to move towards a national system, similar to what happened in Canada with Saskatchewan. So it's just an issue that I think we need to be aware of, that there is strength and depth and experience in the 45, 43 people that are on this call. That's simply incredible, incredible. And working together, I think we can help each other at the state level. We need now to begin to raise close to $1 million together in order to buy a major campaign in order to address all the questions that people are talking about. As we talk about it, it's smoke, it's steam, it goes away in the conversation. We need to translate what we're talking about into cartoons, into narratives, into propaganda. We desperately need to be ahead. For example, what we lost in Prop 186, if you were all old enough to remember, you know, was that we didn't have enough time and we didn't raise enough money to deal with the overwhelming amount of money that was poured against 186 by the organized medical community, the industry. The other thing is, I believe that we're spending an inordinate amount of time, one way or another, looking at cost. Cost is not the issue here. The issue is policy. There's a book by a woman named Stephanie Kelton called The Deficit Myth, which everybody should look at. I mean, she just really blasts away at any attack that we're going to experience, saying that we can't afford to do the right moral thing. And we are in a campaign with a moral imperative. And finally, I want to say that the issue here has to do with fundamentally expanding the model to make public health the foundational ground of all care planning and delivery. We have to radically increase the workforce and change its class, caste, and racial character. And we're not talking about that. And we need to democratize the base of the delivery system such that we must have organized neighborhood health assemblies able to assess what they need door to door, house to house, block to block. We're working on a system that's so centralized, the capital concentration is so poignant that when you talk about Kaiser is just one preliminary model. Every delivery system out there needs to be decentralized, need to be no more than a mile away from where people live, no matter where they live, and they need to be comprehensive. If we're going to deliver comprehensive care, we can't have people driving all over the place to find the right, kind of service. And if we generate over a period of time, once we build the policy opportunity, the right design for the delivery system that's grounded in prevention, early intervention, meaningful respect, kindness, tenderness, home-based services, doctors going to homes, and build a horizontal delivery system that essentially gets away from the vertical hierarchy and money and ego of doctors on the top and everybody else at the bottom. We need the nurses, the dentists, the health workers, the in-home support people in a community of interest. The dramatic example of that is the profound scourge of homelessness that is destroying every city. In order to deal with homelessness, we have to have human beings dealing with human beings in large numbers with great skills and great compassion and great courage.
Absolutely.
So that's the big picture that we're struggling with here. We got to change our conversation from the kind of narrow focus that we're using to look at a larger healthcare, not medical care. The single payer needs to be a healthcare system, not a medical reform system.
Absolutely.
And so we've been working on a model with about 40 or 50 people around the country called the California Lifetime Healthcare Act, which essentially would eradicate Medicaid and long-term care, which is an indigestible lump that is one of the more barbarous public policies in healthcare. We need to get rid of nursing homes as they currently exist and build on individualized planning, like individualized education plans, individualized work rehab plans, and so forth. We have models in the disability community for doing individualized planning. The conversation has to be expanded, and we need to use our expertise to talk to each other about a care model, a meaningful care model,
right,
before we start worrying about how this is going to be paid for or what it's going to cost.
Thank you.
The real system is going to be a wealth generating model.
Thanks, Bill.
Thank you.
Thank you, Bill.
Thanks
for sharing lots of great ideas there. I totally agree with you. They refer to things like what they call wraparound services. Really, it's holistic, healthcare that we're talking about, all the social determinants of health. And as you said, the intersectionality of climate, poverty, racism. Absolutely, we need to be thinking globally in that manner. So totally 100% agree with you.
Read The Deficit Myth and read the Chomsky-Pollan book called The Climate Crisis, The Green New Deal. They're profound and will expand your thinking and understanding of what is at stake here.
Always keep that in mind. Absolutely agree with you. Thank you for that. And then I see Peter, you've been waiting some time. You have another HMO related question?
Yeah, I'll be really brief, and I want to get back to the wonky stuff, if I may, and away from the larger political struggle. Right now, as I understand it, Kaiser hospitals are owned by their insurance division. They've got the legal control over it. How if we were to transition to state funding of those hospitals, would the insurance division basically have the power to just shut them down or discontinue them or screw the process up? I mean, how do we deal with that legislatively as well as politically?
Well, the Kaiser Foundation hospitals are still a existing entity. I don't know that the health plan owns them so much as they contract with them. And when you see, the actual bills, that's the sense you get, is that the health plan is paying the hospital for X services based upon some kind of negotiated rate. Now, it's all internal. I think obviously Steve's right. There's a huge insurance risk factor there. And the health plan is the controlling entity, as Dr. Bill said. But I don't believe they've taken over literal ownership of KFH, unless someone knows otherwise. And so the idea would basically to be you can't, that there's no longer a role for any health plan in contracting for services, that the only entity that can contract for services is the new single payer fund.
Okay, thank you.
I see Steve Kemble nodding his head too. So, so we have agreement from all of our authorities on this subject. Wouldn't it be nice if Kaiser would actually engage in an honest discussion on these things? You know, as a member, actually a partner, I think is what they called us. You know, I'm one of those guys who felt like, gee, I'm actually a partner. And then over the years, I saw how little that actually meant. You know, in terms of like, say, you know, they're Medicare and Medicaid patients. I mean, they deal with single payer payment, you know, right now they're dealing with payment from single payer system. So why is it that they can't transition to 100% single payer payment? You know, beats me. And they won't have that kind of honest discussion about it, clearly, because too many people are, you know, like to lose compensation. So anyhow, world according to me. Any other comments, questions from the group at this point? I'm not seeing any other hands raised. I did see great comment. I can't keep up with all the great comments in the chat myself, but there have been a number of great comments. So if I'm not seeing, okay, now I'm seeing Lynn Heidekover as her hand raised.
Yes.
Oh, hi, Lynn.
Hi. Did anyone see Mark Dudzik's thing in the chat? I see he's left. And it talked about job loss in different parts of the country, whether people could be retrained. And he talked about, I'd have to look at it, but if you can scroll up and see it, it's very important about people getting retrained, the ability for, okay, here it is. Job loss numbers might be misleading unless it is your job that is being eliminated. It doesn't necessarily help the coal miner in West Virginia if they're hiring baristas in Seattle, nor would the displaced administrative worker at a doctor's office in Eureka immediately benefit from the fact that they are hiring community health workers in LA. We must deal respectfully and proactively with the job loss and job change concerns of affected workers, or our enemies will use them as shock troops against us. I thought that was an important comment.
Yeah. Very good.
Sure. Thanks, Lynn. And anyone else? I might take the opportunity to plug our next PDA Healthcare Town Hall on Sunday. We've got Joel Siegel, who I see has been in the group here today. So Joel Siegel is coming to talk about the mood on Capitol Hill from his very learned and lived experience on Capitol Hill, having been John Conyers' aide for so many years and integral in the authorship of HR 676. So we're really looking forward to that discussion this Sunday, 4 p.m. Eastern and 1 p.m. Pacific. So join us on Sunday for the PDA Healthcare Town Hall. Anyone else, if you'd like to, more comments, questions, or announcements even?
Yeah, thanks, Dr. Bill, for guiding us through the valley of the shadow of discontent. Masterful job. I also want to make a plug for everyone visiting the One Pair States website. to look at some of the requests there to put some pressure, a lot of pressure on your local U.S. representatives, senators, and specifically in our state, Senator Wyden, who's chair of the Senate Finance Committee and sits in a position to control whether some of the waivers we seek can go through a reconciliation process. So there's a sample letter you can modify to your own style and send to him, as well as the keep the pressure going for the new HB 3775 bill. It's a dual pressure campaign that we'd like you to take part in. Thank you. And yes, thanks again, Bill.
Thank you, Dr. Mike. Hank, you're
great. Thanks.
Yeah.
So let's say you're a hospital board member, and you're a board member for a hospital in a for-profit hospital, let's say HCA, or you're a board member for a Kaiser entity, hospital insurance. And suddenly Medicare for All occurs on midnight December 31st, and the insurance function goes away. The question is, as a board member or a for-profit hospital or entity like Kaiser, you have to figure, I'm not going to operate in this communism system anymore. We're going to close the hospital, sell the real estate, and we're going to divide up the money among the board members and walk away. And good luck for you, because the real estate's worth more than the buildings. So I think a board member on a hospital, and I was a board member once in a hospital, will go deep and say, we are here to provide health care. We were here to make a profit, but we're here to make health care. So I'm assuming the board of Kaiser, the board of the local HCA hospital will say, we are here to provide health care for the citizens in our community. So that's the question I'd want to ask, let's say, the boards of whatever entity Kaiser is and whatever entity the HCA hospital board would say is, we have this physical structure, we have these physicians, we have this medical campus, we have this integrated delivery system. We need to reorient ourselves to deliver health care for the nation under a Medicare for All system. And I think that is the question you'd want to ask them. And I think that's the question they would answer affirmatively again, or they'll say, screw it, we're just going to sell all the buildings and the real estate and walk away and do McDonald's or something like that instead. So that would be the sort of moral argument I would make to the board of Kaiser and the board of your local hospital, HCA, for-profit or nonprofit or otherwise, and said, what are you here for? You are here to deliver healthcare to the citizens of your community. That's the job you have now, not to make money. So that would be the argument I would make to the Kaiser board or your local hospital board.
Sure. Michael, Steve, last comments on that?
Yeah, no, I think that's right. I think we do need to tap into the sentiment that is out there among folks who are engaged in healthcare and believe that that's their mission, is to provide healthcare services to people who need them. And I'm certain that that's not the position of the CEOs of these insurance companies or even of HCA or Tenet hospitals or other for-profit hospital corporations. I think that there is a sincere belief among board members at Kaiser and perhaps even some of the leadership, but they also have the sincere belief that they're the ones who are best able to allocate services and best able to, design healthcare systems. But they do believe in healthcare, providing healthcare services. And so, yeah, that's the dialogue we want to do. And we're going to have, if our movement, right, were sufficient, we would have won by now. So clearly we're going to have to win over some folks who are not 100% with us now. Clearly we're going to have to engage in the broader justice movement and engage with the racial justice uprising and understand the connections, the social determinants of health and the public health connections around housing and jobs. And at the same time, we're going to have to win over healthcare advocates who have been devoted to the ACA or people who have been operating in that space. So our task is enormous. There's no question about it. And I think, though, if we do approach it as you say, with the moral high ground and a belief in caregiving and the provision of healthcare to those who need it. Let's tap into that. Let's build on that. That's the foundation of the system we want anyway, and that's good politics.
And I always, just to add on, if I might, I always say that Kaiser ought to be proud of the care that it gives, not the money that it makes. So that should be what will drive someone still to want to sign up for that particular care model, to have it all under one roof, like Cindy says, and to have it coordinated the way that they do, the way they coordinate that kind of care. So I think that's all consistent, and that's why I'm still a member, frankly. And they what it's like. What was that company, Amway, used to sell all those products and stuff. It's like people who have all these Amway products on their shelves who actually sell Amway and they use their products. That's what you need to realize, is that it's not gonna work if you can't use the system yourself. Maureen.
Yes, I had one last question for Michael or anybody that can answer it. And that is, I'm curious as to how do we see the opposition opposing us at this moment? With trillions of dollars at risk, nationally, and billions and billions in California, I don't see a full frontal assault other than that HIP group that's pretty anemic. I asked someone else about this and they said, oh, they're not worried because we're never going to get it, so they're not worried. But I don't find that to be a very adequate answer. They've got trillions to spare. Surely a few million to work against us wouldn't be much, a drop in the bucket. So how do we see the opposition right now working against single payer proposals?
Well, this will not surprise you, Maureen, is that they're basically relying upon Democrats to carry their water. And look at, we saw a morning consult poll of the industry during the 2020 campaign, right? When I was working for Bernie. And they estimated there was a 10% chance of Medicare for all happening. And that's when Bernie was leading in the primary. So there is some basis that they believe they've got sufficient protection from this happening. And I think the election of President Biden reinforced that Medicare for all is not immediately on the table federally. But at the same time, you're right, they should be very worried about the level of popular support that Medicare for all enjoys. They should be very worried about a political strategy that starts unelecting Democrats or putting increasing heat on the Democratic leadership to actually guarantee healthcare and control costs. And the fact is that the industry model has no ability to control costs. And that is their Achilles heel. And so since there is huge support for prescription drug price negotiations, for example, and a pretty good chance that can get through Congress, even under the divisions that exist now, that suggests that they do have more to worry about. I think their opposition, what I've seen in these kind of situations, when we get stronger, they start peeling off the usual suspects. So all of a sudden, you'll hear from BIPOC businesses about how single payer will bankrupt them. You'll start hearing from representatives, like, for example, we saw when it came to prescription drug price in California, you'll remember the NAACP came out against that reform. That's the kind of stuff we'll see when we really get serious. They'll start cherry picking natural allies and putting them forward. Oh, you liberals who think this is a good idea? Well, actually, constituencies you care about don't agree. And the irony is that the way to overcome that, I think, is to divide their coalition. Get businesses who are tired of paying these insurance companies exorbitant fees, right, to do nothing and to deny their employees care. So we've got to divide their coalition as well. as they try to divide ours. And I see the industry opposition, it will emerge as we get stronger. And think how much stronger it was. Think all the stuff that Wendell Potter did when he was still at Cigna, right? When Michael Moore's film was getting all that attention. Look at how much money they spent in Iowa against Bernie Sanders in the 2020 campaign. That tells you it's more real than they sometimes let on.
And thanks for the reminder there. Next week in the PDA town hall, we've got Donna Smith doing a Sicko reunion panel. She's got fellow cast members from the Sicko movie. We'll be doing a panel discussion. Should be a lot of fun. And when you think about it, it's almost 20 years, right, since Sicko came out. So which is freaking amazing at this point. But you know, that I think that's what activated me, especially. Barbara Harrison, please go ahead.
I just was going to say the Democrats have to buyer beware. If you look at what happened with the New York Health Act, you have two houses in New York which are Democratic. The governor, the beloved governor, forget about him. He's really, he would not sign the bill. But there was enough to override his veto. And Andrea Stewart Cousins, the leader in the Senate, pulled the bill out of committee and did not give it an opportunity to get voted on. And Carl Hastie pulled it out of the assembly, and the assembly votes every year for the bill when it's up for going. So even though these Democrats run on single payer, Medicare for all, whatever label you'd want to use, when push comes to shove, they turn tail and run. And this is, very spooky. But what I feel is very important is, and I've been saying this for a number of years, we've got to go to the people, got to go to rural areas, got to go to marginalized groups, do a lot of listening. Storytelling is a great vehicle, and bring the facts of where they are and give them tools to empower themselves to come into the movement. The movement is, you'll excuse me, has a bit of exclusiveness to it. We table, we rally, but we're not going to the areas that really need to hear what the truth, and I put that in quotes, the truth is. And those people suffer a lot. I mean, I did a PowerPoint on the healthcare issue in rural areas. So, I think we need to add a different tact to the movement. And in Ithaca, they don't want to go to the rural areas. The Campaign for New York Health, they're not interested. Right now I'm in Eugene, but last I, was there, they're not interested in any of that. But I think it's it's an opportunity to bring everyone together. And how we deal with the politicians, they run on it, you trust them, and then they turn around and screw you, so to speak. So that's a big problem. And the Democrats are not to be trusted. They're very corporatist, many of them. Since Bill Clinton, they've gone really corporatist.
Thank you, Barbara. That's a really good point. And maybe I can toss this back to Michael. And maybe kind of we could consider even wrapping up on this picture, but I know your effort with Healthy California Now has been on trying to pressure or maybe show the governor that he has support in California, for leading once again, especially out of this recall effort that's being imposed on him, on the issue. But isn't what Barbara's talking about really integral to that whole strategy discussion, which is pushing from the bottom up in rural communities, in inner city communities, where more of those discussions, issues-based discussions, town hall meetings, forums, movie showings, that kind of thing. Isn't that what really pushes these politicians, these Medicare for all resolutions that are happening at city councils and school districts and all of that, isn't that going to push the governor, then to actually see that I mean, it's that always ironic thing that the leaders need to be led by the people, right?
Right.
So where do we go from here in terms of gaining that kind of support for these?
Dr.
I think,
Wood,
I think Barbara's right.
Can I ask one question quickly of Barbara? If Barbara would share her PowerPoint or not,
Yes,
if she would, could
I
she
have
put her
no-
information in the chat? I would love to see your
can you do-
PowerPoint. Sorry to
Can I
interrupt.
put sorry, can I put the PowerPoint into the chat?
How about posting your email in the chat?
Okay, why don't I do that? Because
Right.
Maureen, I was able to get yours. I'd be happy to share my PowerPoint, and I'd be happy to share my storytelling workshop.
Thank you. Thank you.
Anything, and if I'd love to find people to work with who are interested. I just feel I've studied this. I really want to make change before I die.
Right.
So I'm going to put my email right now into the chat.
Thank you so much.
So I think just to wrap it up, sorry, I should get going, but I think Barbara's right. I think that one of the groups that's doing organizing in rural areas is People's Action. I'm on the board there. They're taking very seriously engagement with rural communities and understanding that we're not going to change the Senate unless we can change some of these states that are heavily rural, who are electing just Republicans, for example. We are focused on Governor Newsom because we learned a lesson from other states and from national that executive leadership matters. But we're not asking him, we're not a supplicant, and his moves so far are inadequate. What we're doing is we're basically saying we're going to create a condition where it's in your political interest to do what we want, regardless of whether you want to do it. And you're exactly right, Bill, that starts bottom up. And as Dolores Huerta said earlier this week at a town hall Healthy California Now hosted Monday, when she was asked, well, look at all this money that the governor gets from the health insurance industry. And she said, ultimately, money doesn't elect politicians, voters elect politicians. And he depends upon our votes. And that's what we have. And the polling shows that if he leads on single payer, people are more motivated to oppose the recall. He's got a primary election a year from now. If he hasn't delivered on single payer, why shouldn't this be an issue in his reelection, right? We have the opportunity. We need to find them. We weren't successful nationally in defeating Richie O'Neill, and it had direct consequences in the sense that a very inadequate surprise medical bill that is in the interest of private equity and other industry interests got through because Richie O'Neill, chair of House Ways and Means Committee, wanted it. Had Alex Morris defeated him and he was actually undermined by dirty tricks, that would have been different. We can elect Pilar Schiavo in AD 38 in California, who would be a strong single payer proponent. So electing people, unelecting people, these are the messages. They have to be more afraid of us than they are of the industry money on the other side. And what we got is votes. And so we have to tell our stories. We have to engage in those rural constituencies that haven't been with us. Let's face it, there's a politics of resentment in play. Some people are getting a better deal. The only way to overcome that is to give everybody the same deal, guaranteed health care, no barriers to care. And ultimately, our power derives from people and our ability to make these politicians do what they wouldn't otherwise want to do. And that's the lesson.
100% agree.
Michael, the other thing is we have to also, take into consideration the gerrymandering, even more so, that's going to take place. The Republicans have the majority of legislatures in the states, and the Democrats lost seats in the 2020 election in the House. So, this is really, we need to be on the ground, but we cannot do this as intruders. We need to be invited into these communities by making relationships with someone in that community. Because yes, we are uneducated. Most of us, without looking at stats, have degrees, have been out in the system. These people have been so marginalized and taken advantage and have their emotions, as Trump did, play played upon.
That's what I think, Barbara, People's Action is doing, precisely that. Integrated into those communities, working with those communities. And we see examples of that in southern states. We see that throughout the country, and we obviously have to do it in rural Oregon as well. So
yes.
I think there's no substitute for one-on-one organizing and building those relationships.
Well, let me just kind of wrap it up and thank you. Thanks, Barbara, for those comments. Thank you, Michael, so much for presenting today. I thought that was another terrific packed presentation and discussion that followed. So really appreciate that. And thanks, everybody. The OPS group continues, in our work. It's always an honor and a pleasure to be with everyone. So, we all wish Chuck the best. And thank you, Dr. Mike Huntington. I'm going to turn it back over to you at this point. Very much appreciate your work too, of course.
Thank you all. Thank you, Dr. Bill.
Thanks, Dr. Bill, and thanks everybody for coming to this meeting. Hope to see you soon again.
Stay healthy, everyone.